My talk is to tell you about brain tissue oxygen tension monitoring. I guess the reason for me being invited is, well, that's Edinburgh, but it's not because I come from Edinburgh. It's because I'm a user of the device. Briefly, you should know that I'm supported in my travels here, and I'm grateful to Integra Neuroscience, but they are a manufacturer of a device for monitoring brain tissue PO2, and you should know that. So, we're thinking about, for a 50-minute lecture, I can't cover all the possible uses of brain tissue PO2 tension monitoring, so I'll focus largely on traumatic brain injury, but the principles apply across many of the sort of acute brain injury disease processes. So what do we know in traumatic brain injury? Well, we know that low blood pressure is common. We know that traumatic brain injury patients get many systemic complications of their injury. And we know that having a traumatic brain injury alone causes an increase in pulmonary complications. But outcome, functional recovery of these patients, survival and functional recovery, is dependent on the extent of so-called secondary insults. Now, this was a subject of investigation when I was a fellow with the late Douglas Miller. But these are events known as hypotension, hypoxemia, raised core body temperature, and low cerebral perfusion pressure, mean arterial pressure minus intracranial pressure. There are also autopsy evidence from many studies showing that the people who do not survive their traumatic brain injury have very strong evidence of ischemic damage. Now, this leads us to the conclusion that following a traumatic brain injury, there are events possibly related to these physiological abnormalities that result in worsening damage, possibly through ischemia as a mechanism. Now, yesterday I was delighted, I think, to be referred to as a forefather because I had been involved in secondary insult research. This is a computer screen from way back when, in the 1980s and early 1990s, when we collected very detailed physiological data. I'm sure you can't read it, but it's blood pressure, intracranial pressure, all these secondary insults I mentioned earlier, at 1-minute intervals. We were able to summarize them offline in further software called the Edinburgh Browser and produce this insult chart, which summarized the amount of abnormal physiology that individual patients had suffered during the acute phase of their management following traumatic brain injury. The 3 insult grades were really just based on expert opinion, but grade 3 was very significant physiological derangement. Well, what did we show? Well, it really is a long time ago now, but what we showed was there was a very strong association, this was observational research, between low systemic oxygenation, arterial hypotension, and raised intracranial pressure. There was also an association with raised core temperature. So these were, for us, the key and the sort of fundamental so-called secondary insults that were associated with worsening physiological outcome. So that was a very labor-intensive and complicated way of assessing the burden of so-called secondary insults. This paper, which is a little bit more contemporary, not terribly new, from Ross Bullock, looked at a very simple schema where they just assigned 1 point for presence or absence of, again, systemic hypoxemia, systemic hypotension, and that really is marked hypotension. They measured cerebral blood flow, so if there was absence of low cerebral blood flow, herniation syndromes, or low cerebral perfusion pressure. Presence or absence during the acute phase of admission just gave the patient a single point. But they showed really quite a striking relationship between presence and absence of the so-called secondary insults and functional recovery at 6 months by the 5-point Glasgow outcome scale. Of almost equal interest was they were able to show a relationship between increasing hypoxic secondary insult burden and physiological derangement using microdialysis, whether it was lactate or glucose or pyruvate and glutamate. So not only was functional recovery related to these so-called secondary insults, but brain sort of biochemistry was as well. To try and unravel this issue a bit further, I collaborated with a professor of artificial intelligence who was particularly interested in machine learning, and my good friend and colleague, Mr. Statham, senior neurosurgeon in Edinburgh, were involved in this process. And what we did was we took all of the admission demographic data, that minute-by-minute physiological data from the Douglas Miller era, and put it into what's called a regression tree. The regression tree subdivides patient groups into more homogeneous groups with nodes as the discriminators. The highest node is the most powerful discriminator, and the lower nodes are less powerful discriminators. And if you run the process without any limits, it puts each patient almost in a category on their own. And as we know, patients and ourselves are all individuals. However, if you get it truncated, you can produce a schema like this, which just shows that the most important discriminator of functional recovery is any episode of low blood pressure, and that was more powerful than pupillary response, mechanism of injury, and GCS, as you can see, I don't think it's even on that scale. Now that's maybe in part due to the quality of primary hospital GCS reporting, but as you can see, the physiological derangement of low blood pressure is high up in this order here, and even grade 1 modest hypotension was a very important discriminator. So this further sort of established the principles that we had to prevent secondary insults because they might cause brain ischemia in the acute phase following a traumatic brain injury. Now, if you look at the Brain Trauma Foundation guidelines, we don't have very much level 1 evidence, i.e. evidence from randomized controlled trials. But if you were to summarize the evidence and what it says about the acute management following traumatic brain injury, it is maintain oxygen delivery to the injured brain. Pretty simple concept. But it does beg the question, if we have technology that can actually measure oxygen delivery to the injured brain, why don't we do it? Additionally, in intensive care and in critical care, a lot of the things that we do dramatically alter cerebral blood flow and therefore cerebral oxygen and substrate delivery, whether it's alteration of cerebral perfusion pressure, whether vasoreactivity is intact or lost, whether we hyperventilate the patient. Although we do know in our experiences that with hyperventilation, you do ultimately get metabolic compensation. But acute hyperventilation causes a reduction in cerebral blood flow, and these are data from David Menon's group in Cambridge using PET scanning, and it just shows a reduction in arterial CO2 from 5 kilopascals to 3.3 causes a widespread reduction and an unpredictable reduction in cerebral blood flow. Way back when I was working with Douglas, we used jugular bulb oximetry. That's placing a fiber optic catheter high up in the internal jugular vein at the base of the skull, and we could measure cerebral venous oxygen saturation. And first thing we did, like anybody who has a new device that measures adequacy of oxygen delivery or cerebral blood flow, is to alter CO2. And you can see here, cerebral oxygen extraction goes down when CO2 is raised, and it increases again with hyperventilation. So even in injured brain, there's evidence that the things we do, either but on purpose or inadvertently in critical care department, alters cerebral oxygen delivery. We abandoned using jugular venous oxygen saturation partly because the quality and the validity of the recordings is poor. Possibly half of the recordings are unusable. And after about 24 hours, what we found was that you got a large percentage of patients who ran with quite high jugular venous oxygen saturations, showing that there was an uncoupling between cellular metabolism and flow, certainly with these global measures. This is a paper that we reported some time ago. So measuring at the downstream end was not helpful. This led us to investigate and use this LICOC system here. It's probably the most widely used brain tissue oxygen sensor, and I think is the most sort of robust and user-friendly. It's a miniaturized Clark electrode, sits in brain parenchyma, and those of you who were at the workshop yesterday will realize this triple lumen bolt system is actually very simple to use. And I apologise to the workshop attendees because they've heard a lot of this before. So it's a straightforward system. It's robust technology. It's been around for quite a while. One of the questions my colleagues always challenge me is, this value that you get somewhere, hopefully between 20 and 30, if we're in a good place, does that actually relate to physiology? Now, this is a study that was done in the laboratory, and this is multiple oxygen sensors. This is schematic only. Multiple oxygen sensors placed over a small vessel on the surface of an animal, a live animal preparation. And they were able to measure oxygen tension in the middle of the vessel, at the wall of the vessel, and then a gradient out into the parenchyma. And this, I should say, this German group had no relationship with the manufacturer, and reassuringly, they found exactly the sort of oxygen tensions out here that we detect using the monitor clinically. So if this device was going to be helpful for us to titrate cerebral blood flow through either hyperventilation or vasopressor support, there ought to be a relationship with cerebral blood flow. So this is data from non-injured laboratory animals published by Claude Hempel from UCSF. But you can see here, I think, there is a good relationship with cerebral blood flow. If you look with mean arterial pressure, again, and brain tissue PO2, you could persuade yourself that you see the autoregulation curve. In fact, I actually think these data look more convincing than the original 1970s autoregulation data. And CO2, our favorite for modulating cerebral blood flow. In the physiological range, really a very good relationship. So it might be that this monitor, if placed in structurally normal tissue, might be a very useful monitor for guiding and individualizing our therapy in our acute brain injury patient. A few years back, I was asked, what cerebral perfusion pressure should we use to prevent brain ischemia, and can one sort of number fit all? Well, I think that's clearly not possible that we can produce a single figure, but there has to be some principles. So we want to set our CPP at a level that minimizes this secondary ischemic injury, but we also want to set it at a limit that reduces the complications of CPP therapy. We know from Claudia Robertson's data that vasopressors and fluid loading resulted in a 5 times increase in ARDS. The numbers that you get from the Brain Trauma Foundation guidelines are population-based. So you get an average value that might suit the majority of patients or the median patient. But I believe really that this should be individualized, but we need an endpoint against which we titrate the modest changes in CO2, arterial pressure, and ICP. And it could well be that brain tissue PO2 might provide that. Here's some data. This just shows, A, that the device does what we would like it to do, but also shows us that it's better and safer than jugular venous oximetry. So Lycox used for 9 days, SGVO2 used for a median of 4 days, but required repetitive calibrations. Lycox does not require that, and in this series they had 55, more than half of the calibrations were out by greater than 5%. Poor intensity, light intensity from the catheters bedevils this sort of monitoring, whereas Lycox was much more stable and 95% of the data were good. Quickly going back to measuring brain ischemia, David Menon has looked at oxygen extraction fraction as a sort of surrogate for brain ischemia. And what you can see here is a study with 10 volunteers and 15 patients. V is for volunteer, TBIs, the TBI patients. And you can see that there is still a normal distribution pattern, but it's much, much wider across the base. This is actually common to all physiology in acute illness. But what it meant was that following TBI, there's a large percentage of this bell curve out with the greater than 75% oxygen extraction fraction, and has been termed by David ischemic brain volume. If you use SGO2, it's unable to detect ischemic brain volume until the volume is really pretty significant, somewhere greater than 100 ml. So another reason for adopting a new technology. And there is a relationship with low levels of brain tissue oxygenation. This is in apparently structural normal tissue following trauma. Levels below 20 with increasing severity are associated with adverse outcome. So the monitor seems to monitor the physiology that we can manipulate in the critical care unit, and there's also a pretty robust relationship, which has been shown by many people, with functional recovery. This paper from Nino Stacchetti's group I found slightly disturbing in that they were able to show in perifocal tissue, but also in normal appearing tissue, that there were episodes of low brain tissue PO2 that were not related to grossly abnormal cerebral perfusion pressure, mean arterial pressure, and ICP increases. So monitoring these pressure variables and manipulating them does not guarantee that you can prevent these episodes of low brain tissue PO2, which we know are associated with poor outcome. There's a meta-analysis showing really exactly the same thing. The more episodes of low brain tissue PO2, the worse your outcome is. But if you look here, of almost 300 Lycox insertions, there were only 2 small hematomas, and that reflects our experience in Edinburgh. You know, even the critical care consultant and residents will put in the Lycox monitoring device. And in fact, nowadays, our bed space nurse demands that it's put in, because otherwise they feel that they're looking after the patients blind. They don't know what they should be doing in terms of blood pressure management and ICP treatment. Such is the sort of robustness and the sort of validity of brain tissue PO2 as a physiological monitor in acute brain injury. I was going to move on quickly. I got my slides out of sync there, excuse me. So what can we do? There's very little evidence for many of the things that we do in critical care to manipulate CPP and particularly ICP. If you look at the total number of patients in trials for barbiturates, hyperventilation, and mannitol, they're tiny. The summary estimate of effects really don't encourage you. So what should we be doing? Well, if we actually have brain tissue PO2, we can target it. And there are many other things that we can do other than just using, these therapies do reduce ICP, but we don't know if they improve outcome. We don't know what they do to brain oxygenation. But we could possibly increase ICP. We can control ICP, increase CPP. Maybe we should, increase CO2, something that we never used to do when we weren't monitoring brain tissue PO2, hemoglobin transfusion, or increase FiO2. Increasing FiO2 we do only to test the monitor function. Otherwise, we leave our PaO2 within tight limits so that changes in brain tissue PO2 are related to perfusion changes. But yes, we can increase CO2, and there are case series to show that this is actually quite a valid and reasonable thing to do. This is a study here, before and after, where they had an ICP and CPP targeted cohort and a brain tissue PO2 targeted cohort. When the brain tissue PO2 cohort also had ICP and CPP targets, but the limits were much, much wider, much more liberal, with ICPs up to 25 or 30. And what they found was targeting brain tissue PO2, not surprisingly, it was higher, but also the number of episodes where it was low were fewer. And the patient's outcomes were, it was only 93, so it's clearly not powered for outcome, but were comparable with contemporary series. Here's a simple study, but they used brain tissue PO2 as an endpoint to assess 2 different hypertonic treatments. And such is the sort of robustness of the monitor that it's accepted to a peer-reviewed journal as the sort of primary endpoint for the study. In this case, they showed improvement in brain oxygenation in the sort of apparently structural normal region with hypertonic saline compared with mannitol. If you want some guidance on which patients could benefit from monitoring, which side to monitor, injured, uninjured, then I would recommend this European guideline that was produced with my colleagues Giuseppe Citterio, Luca Longhi, and others. But one of the key questions that we tried to address in this consensus was, when should brain tissue oxygen tension actually be monitored, and should we be looking for structurally normal tissue, abnormal, or maybe even monitor in more than one place? So when? Well, we know low PO2, again, we've had this before, is associated with these physiological changes, ICP and CPP, but it's also associated with adverse outcomes. And although we couldn't recommend, there are no level 1 evidence to recommend it in all patients, the feeling was that we should be monitoring it in most of our ventilated and ICP monitored traumatic brain injury patients. The data in subarachnoid hemorrhage was less strong. So that's the device. This is just a picture of a patient. Usually you would expect to see it right frontal, but this patient had absolutely enormous bifrontal contusions. There's a pressure monitor here, and posteriorly there's a pressure monitor, temperature, and oxygen monitor. So where should we put it? Well, this is the CT scan of the patient. Well, it depends on what information you want to find. If you actually stick the oxygen electrode in that contusion, hemorrhagic contusion, you probably won't learn very much other than the oxygen tension is very low and there's very little you can do to improve it. But I would recommend localize it, the location of the device should possibly be individualized. Where right frontal is not going to be used, have a look, review the scan with your neurosurgical colleagues. There's certainly something to recommend monitoring around potentially salvable tissue, whether it's pericontusional or under the evacuated acute subdural hematoma. Eloquent locations must be avoided. So, in conclusion, we use brain tissue PO2 as a perfusion monitor. Clearly, it measures oxygen, local oxygen tension, but if hemoglobin is constant and you have tight control over your arterial PO2, it provides a very good perfusion monitor. We believe it's a good measure of physiology, and in our unit, where we're using it much more widely, it does affect our treatment strategies quite dramatically with a movement towards improving oxygen delivery. We believe they're safe, stable, and provide high-quality continuous data, which is exactly what you want from an ICU device. An issue that often troubles people who start using the device are low PO2s at insertion. It's almost universal, and there's the ongoing debate about the best thing to do. Usually what is done is it's left for I explained to the nurses, for the electrode to equilibrate, but that takes up to about 60 minutes. Thereafter, the robustness and reliability previously described are pretty evident. So I just want to finish with some shameless advertising from a clinical trial. If you're interested at all in ICP monitoring and management, please go to the website. The trial's registered both as Neurotherm, because non-European countries don't like Eurotherm. But that's the... Well, I've cut the website off. Anyway, thank you very much for your attention.
Dear Chairman, ladies and gentlemen, dear colleagues, it's a great honor for me to be here in the Arab world. It's my first visit. I guess we've all had lunch, so it's like those days in medical school after lunch when you had your first lecture. My mission today is to talk to you about targeted therapy in neuro-ICU employing two monitoring techniques, namely ICP and PTO2 monitoring. Peter has just set the ground for me, and all good lectures on an occasion such as this start with a review into what's been reported before. What I'll address today is the concept of intracranial pressure, and namely that blood department here. Remember, what we're doing in an ICU is we're applying physiology to a sick patient under conditions that are as close we can get in a clinical situation to an experimental setup. So we have a lot of toys and tools to play around with. We have a lot of numbers we look at and a lot of dials we turn. The concept that the intracranial cavity is a fixed space with a fixed volume dates back to our forefathers, which have reported on that in 1783 and another paper published in 1824. And I was lucky enough to get a hold of a copy, which I could not photograph, but all I could do is write down. And I think this is one of the first description of a loss of cerebral blood flow and cerebral blood volume, because what the author here says that whatever additional volume you add to the cranial compartment, the blood is the one that's losing because it'll be pressed out of the brain. And the blood compartment is what I'll focus on today. This is sort of the current concept of cerebral autoregulation. And rather than looking at static numbers today, I will talk about a dynamic system. That is the concept of integrating autoregulation and the autoregulatory capacity into your treatment concept. And that is based on a fundamental that, as we've all learned in school, that cerebral blood flow needs to be maintained at a certain level in the brain, and that there is very little alteration and flow. The blood, just like the brain, just like the retina and the kidney, like a very constant blood flow. Now, the most fundamental level that there is to maintain that need for flow is the metabolic autoregulation, and that is an evolutionary thing that dates way back. How do we assess that? Well, if we hyperventilate, we faint, and we faint because of a loss of cerebral blood flow. Now, on top of that comes a modulatory mechanism which we call pressure autoregulation. And when I was a resident and a registrar and a trainee, even as a fellow, I was told that pressure autoregulation is always lost after severe head injury. And one of the messages that I want you to take home today is that that is not the case. Let's review on the metabolic autoregulation. That's what's been called the cerebrovascular reactivity. And in other words, it's the change in cerebral blood flow that we get or we lose with every change in PaCO2 that we carry along in our arteries. And that is per millimeters of mercury, a 4% change. Now, that is quite a significant number. That is the slide, the chart which we've seen before, which I'll keep using, so I'll explain it to you. What we always see on the x-axis is a reference to blood pressure. Now, sometimes that's arterial pressure, and sometimes that's cerebral perfusion pressure. On the y-axis, when we see these cartoons, sometimes it's cerebral blood flow. So that is a measure of flow. It can be blood flow or blood flow velocity. Now, once again, what we do when we hyperventilate somebody, we bring cerebral blood flow down to critical levels, and that can be achieved by just changing PaCO2 just a few millimeters of mercury. We know that challenging the system does tell us about something how the patient will do. That is the old outcome study on cerebrovascular reactivity. This is works from Don Marion and Howard Jonas, and other people have told us that. Basically what it shows, if your reserve mechanisms are lost, you are in trouble. In other words, if you cannot adjust to the needs that your body position or other things you need to confer with are impaired, you are in trouble. So far and so much about the metabolic autoregulation. Now, the pressure autoregulation is what I want to talk about today. Now, what we see here is a tracing of three parameters: arterial pressure, PA pressure, pulmonary artery wedge pressure, and ICP. And I did this during my fellowship. It was my task in the morning to review the night's charts and see what happened. And Randy Chestnut, who was my mentor at the time down in San Diego, we noted something. We noted that for every drop in blood pressure here, indicated by the vertical lines, we would get an ICP spike. Now, classically, you're being told that this is some sort of Lundberg A, B, or C wave. However, if you go back to the original literature, you will find that the Lundberg waves are not preceded or accompanied by changes in blood pressure. So we went on to see that as well here. Look at that. This is the blood pressure that drops for some unknown reason. And it goes along with the CPP decrease because what we see here is an ICP increase. Every drop in MAP was followed by an ICP increase. Once again, that was reproducible, and we saw it in a lot of patients. So we asked ourselves, well, pressure autoregulation isn't lost in these cases, is it really? Once again, another example, once you start looking for something, you'll find it. It's like when you have a new car. You look around in the streets, and all of a sudden, you see your car more often than you've seen before. So once you become alert of something, you keep looking for it. What we've also noted is that if you take instances where blood pressure was changed, and you look at the ICP, we saw two different response patterns. One was that upon an increase in arterial pressure, we would see patients where the ICP would go up, and once the pressure, the inotrope, was dialed down again, the ICP followed passively. Now, on the other hand, we saw patients where an increase in arterial pressure was accompanied by a drop in intracranial pressure, and when the pressure was brought back down to starting levels, ICP went up again. So, like I said, once you start looking for things, you will find them, and we had to ask ourselves the question, well, can we exploit this intrinsic autoregulatory mechanism for ICP control? That's sort of an appealing idea. Let me summarize the physiology behind that. That's the chart which we've seen before, and it basically shows, once again, on the x-axis, the increasing pressure, in this case cerebral perfusion pressure, and here the cerebral blood flow. Now, what I've added to this slide is the aspect of the cerebral blood volume. Now, that is the degree of vasoconstriction, which is one of the compartments of what makes up the intracranial pressure. So this is sort of the classic concept of the plateau of cerebral autoregulation. If we put the ICP on top of that, derived from the cerebral blood volume, we do see a decrease in intracranial pressure. So that is the concept of the active autoregulation, whereas here, the loss of autoregulation, we would see a pattern such as when we increase cerebral perfusion pressure, we will see an increase in cerebral blood flow because of what's called vasoparalysis. That is, the diameter and the lumen of the arterial side of the vessels passively follows the cerebral perfusion pressure. Now, if we put ICP on top of that, we will see that there is a correlation coefficient of 1 within this system. People will argue, now, the changes in cerebral blood volume that are induced by these mechanisms are quite low. However, please be reminded of the concept of the intracranial compliance. Now, that may be true in a patient in which ICP is not a problem. However, because of the changing compliance or the so-called reserve, small changes will make a big difference. When I showed this to my dad, who's a neurologist, he says, well, that's easy to explain. When I did my pneumencephalograms in the 1960s, the last 2 milliliters that we put in the ventricles in terms of air would make the patient from posturing to getting back to normal. So yes, small changes in intracerebral volume can make a big difference in a patient in which the compliance is compromised. We started a study then. We started to systematically increase the pressures and let them drop down. We would call that the ramps. And we would study what the effects were not only on intracranial pressure, but also on oxygen, PbIO2 or PtIO2, and also on cerebral blood flow velocity. Cerebral blood flow velocity we measured with the TCD. I guess most of you will be familiar with that concept, and that it correlates as the first mathematical approximation with true cerebral blood flow has been confirmed in a lot of studies. The question is, how do we grade that? Remember what I told you, if two parameters follow each other passively, you get a correlation of 1. And if you increase one and the other one doesn't move, you have a correlation of about 0. And if one increases and the other one decreases, you get a correlation that goes to -1. So Marek Czosnica, whom I met in the mid-90s, at the time was developing his now well-established indices of autoregulation called MX and PRX, and that's how you can grade that. So this is our protocol. Mean arterial pressure goes up, and we look at how the other parameters do change in keeping with that. What are the results? Well, the results were a bit surprising to us because it showed that even in the injured brain, these are 20 patients at 80 challenges, 80 blood pressure challenges over time, we did see a plateau of cerebral blood flow indicated by the Doppler velocity at this time. So it is not correct to say that autoregulation is lost after head injury. What we also found was, and that pretty much within the same margins where we saw active pressure autoregulation, is that we saw PTiO2, that is oxygenation autoregulation. It also plateaued at that level. Now that's also a new concept that has been meanwhile confirmed by others. This also shows again that autoregulation is intact and that in most patients you will be able to exploit this preserved mechanism to bring down ICP by physiological means. Our patients that we investigated seemed to like CPPs between 70 and 90. These were pure changes induced just by changing blood pressure and not by using any other means such as CSF drainage or other things. This is the summary of that. For those patients with intact autoregulation, we were able to see that we were able to achieve ICP control. When it comes to looking at that with the Lycox probe, this is a very simple example here to shine light on the issue which CPP should be good in a given patient. Thank you for the reminder. It is to show you that in this case, a CPP of about 60 is enough to achieve sufficient oxygenation, whereas in this patient, a CPP of 100 is needed to achieve good oxygenation levels. We were also to show in a follow-up study that the time course of autoregulation varies after the injury and that pressure autoregulation, although impaired to start with, does improve later on. Ladies and gentlemen, I think we're seeing a bit of a change in the dogma here. We're learning that we can exploit these mechanisms. We can see that the autoregulatory capacity, challenging the system in a dynamic fashion, can be integrated into a treatment algorithm. Thank you very much for your attention.
Thank you. Thank you, Professor Kassel. Our next guest speaker is Dr. Bernstein again. He's going to talk about awake anatomy for brain tumor removal.
Okay, great. So this is a non-physiological talk. It's about an experience with awake brain surgery for brain tumor removal. So why should we operate on patients awake? It avoids the morbidity of general anesthetic. It's faster than craniotomy under general anesthetic. It allows for mapping of the cortex to decrease neurological complications and maximize the degree of resection, if you're a believer in extent of resection for gliomas. Less resources and less complications. So pulmonary and other complications are less neurological complications, less resource utilization, and less cost. And one of the resources that you use less of are ICU beds. And in many parts of the world, including here, ICU beds are at a premium, and if the patient doesn't have to go to an ICU bed, it improves the flow of patients through the system. What kind of patients would be benefited by an awake craniotomy? Any patient with an interaxial tumor, and we've done a bunch of meningiomas as well. and particularly for lesions in eloquent cortex like this lesion where there's some cortex to cut through, and it'd be very nice to know that that cortex is silent before you incise it. Non-candidates are patients with dysphasia, confusion, or somnolence, tumor location necessitating an uncomfortable body position, and increased ICP is not an exclusion to awake craniotomy. The brain behaves beautifully with the patient breathing room air. The protocol is simple: education of the patient preoperatively, same-day admission at 6 a.m., MRI at 6 a.m. for navigation, non-invasive anesthesia monitoring, steroids, antibiotics, positioning with padding. And this is a simple setup with the patient and the nurses and the doctors. We fix the head with Sugita pin fixation with xylocaine, register the navigation device, produce an adequate scalp flap. They're almost 95% are linear, almost always linear flaps. Local infiltration circumferentially with 0.25% Marcaine with epinephrine, the same kind of anesthetic the dentist uses, and draping the face free. This gentleman, we don't shave the head, but this gentleman happened to be bald. So if you see the curvilinear incision and the dots mark where we infiltrate. So that you have to infiltrate a ring type of block so when the retractors go in, it doesn't hurt. And there he is while we're operating, very comfortable. Standard scalp and bone flap, use of navigation to locate the tumor, cortical mapping, corticotomy to avoid functional brain, and then standard microneurosurgical technique to remove the glioma or the metastasis or the meningioma, whatever it is. That's just an example of some bipolar stimulation. And then finally, we monitor the patient for 2 hours in the recovery room and then transfer to the ward. And they are discharged home the next morning or the same day. And I review them a week or two later to discuss the pathology and the next steps. So how do we cortically map? We use a bipolar stimulator these days with 100 microsecond square wave pulse, 50 hertz rate. We start at 8 milliamps and go up as high as 16 milliamps, and we map for the appropriate functions. Speech mapping is done by counting, naming objects in photographs and the like. Motor mapping by strength testing. Positive cortex is labeled with numbered tickets, and a birth of 1 centimeter is respected, if possible, from positive cortex. Some people say larger, 2 centimeters. I try to stay at least 1 centimeter, and that still allows a resection. So here's a simple example. This is actually a 16-year-old girl who was operated about a decade ago, and we've got a subcortical non-dominant tumor right under her motor strip. That's an artist's rendition of her head. That's the shave and the incision. And the black outline is the bone flap. The pink is the surface projection of the tumor. You've got a big vein there, the vein of death. And when we stimulated F, we had foot weakness. T was tingling on the thigh, and C was tingling on the calf. So where do we cut to safely take out that tumor and prevent this 15-year-old girl from living a lifetime with hemiplegia? We use the back of the sulcus and a bit of that silent gyrus. And the tumor's out, and there she is a day or two later, and she's doing well. It was a papillary glioneuronal tumor, which is a benign neuroectodermal tumor. Here's just another example of mapping of this large, low-grade glioma. Interestingly, speech was spread out all over the place in this case, and there's post-resection. So what resources have we used over the years? So we very rarely use urinary catheters, arterial lines, CVP lines, endotracheal tubes, and ICU beds. And not only is this cost effective, but of course it's complication effective. I've had 0 urinary tract infections in the awake craniotomies, 0 pulmonary emboli, 0 deep vein thrombosis. Median hospitalization has been 1 day. So in my last 2,000 tumors, you can see that the yellow, which is the awake craniotomies, are a substantial piece of what I do. So 961 cases had an awake craniotomy for tumor removal as of last week, mostly adult patients, 2/3 gliomas, 1/3 metastases, and mapping significantly altered how the case was done in 1/3 of cases. So the predictive value of mapping, when mapping is positive, there's a 6% chance of a new neurological deficit and a 15% chance of a worsening of an existing deficit. When mapping is negative, there is a 2% chance of a new neurological deficit and 12% chance of a worsening of an existing deficit. So it gives us an idea, as we're on the fly during surgery, whether we're going to expect a deficit or not post-operatively. We've done some qualitative studies, which I'll share with you later in the afternoon, but this one qualitative study of patient satisfaction, we asked patients in interviews, are you satisfied with awake and outpatient craniotomy for brain tumor? Satisfaction was high. Patients are initially surprised it can be done, and trust in the surgeon and the system is what gets them through it. So lessons learned. Awake craniotomy is practical and easy for the surgeon, the anesthetist, and the patient. It's faster than craniotomy under GA, less resources used, so cheaper, lower complication rate, so safer. Easy, faster, cheaper, safer. I call that a win-win-win-win. Lessons taught. I've had the privilege of teaching this around the world, and this was the first one done in Indonesia 10 years ago, and the first one done in central China 4 years ago, and the first one done in Ghana last year, and now my current project is Nigeria. And maybe we should be doing some more in the Kingdom of Saudi Arabia. I know that you do some here, and hopefully I would like to encourage you to do more. It's a great operation. So let's look at something really absurd that arose out of the awake craniotomies. If at first the idea is not absurd, there's no hope for it, and that's outpatient brain tumor surgery. That's where the patient comes in the morning and is eating dinner at their dinner table that evening. So they're outpatients. So in the last 15 years, I've done a few Ommaya reservoirs like this, 130 biopsies, but 378 craniotomies. This is where a patient comes to hospital, has their tumor removed, and does not spend a night in hospital. And these are not all small tumors. Here's an example of a large anaplastic ependymoma, only one of these tumors in my career. That's her post-op CT 4 hours after surgery, and we do a non-enhanced CT just to make sure there's no blood. Here's a recurrent GBM, not a small tumor, post-op. She's home that evening. A deep breast cancer met. It's out. She's home. So outpatient awake craniotomy is a feasible treatment option for many patients with brain tumors. Maybe it's not practical in your culture, but maybe it is, if it's given a try. But I would encourage you to start with more awake craniotomies. I think it's a terrific operation for all the reasons I've stated. And here's a happy gentleman on his way out the door 5 or 6 hours after surgery. And I would just like to acknowledge the chair that I recently got, which helps me fund my projects in the developing world like Nigeria and Ghana, etc. So this is what you're missing. This actually isn't the winter this year in Toronto. We had a very light winter, but this is a typical winter in Toronto. And many of you have visited Canada or the United States, and you've lived there for a year or two, and you've experienced our winters, which is really quite beautiful. And this is a frozen lake, and we ice fish on frozen lakes. That's one of my British fellows from a year or two ago, holding some beautiful whitefish that he caught through the ice. So we make a hole in the ice and we dangle a line down it. That's the Toronto Western Hospital, which many of you in the room have seen up close and personal, and that's from Lake Ontario with the CN Tower. And I thank you for your attention.
Thank you, Mr. Chairman, and a special thanks for the organizing committee. This talk going to be a little bit different and shorter. We are going to shed the light on brain-machine interface and neuroprosthesis. We're going to cover the background, data collection methodology, techniques, technologies, and clinical applications. Brain-machine interface or brain-computer interface or neural interface is a direct communication pathway between the brain and external device. And the aim of that is to assist, augment, and repair a lost neurological function, either sensory or motor. It can be input interface or output interface, like cochlear implant and BMI. Starting with the input interface, include cochlear implant. Many patients in the face of this planet received cochlear implant. When you don't have the cochlear nerve function, you do auditory brainstem implant, and this was done in 1979. You have two types, penetrating ABI and surface ABI, as you can see here in the picture. And in a study of 60 patients, where about 12% they started to use the phone and communicate after this implant. Now moving to visual cortical prosthesis, first implanted in 1968. And when they implanted this one, what they use a camera in the front of the eye, connected into a glasses and connected into the visual cortex, and they stimulated the visual cortex by just electricity-inducing phosphines. Then another study was done by John Gerfen group, where they studied 2 patients. They put a grid over the visual cortex, and those 2 patients, they were able to see some light and recognize some light. The problem with visual prosthesis, you have only 256 electrodes, and in the visual cortex you have billions of neurons. And the new technology now is to transform percutaneous and wire technology into wireless technology. Moving to the output interface, the rationale is to help patients with limb amputation, quadriplegia, and locked-in syndrome, is to improve communication, mobility, and entertainment. This is an example for prosthesis. This is what's the mechanism, is to connect the prosthesis into the proximal muscle EMG. It is an EMG-dependent prosthesis, and the patient can use it to restore the function that has been lost. The other thing is to use a small device that can stimulate the muscle to contract. This is an example for the neuroprosthesis. This person is able to drink a coffee using this prosthesis. Now moving to the brain-machine interface, which is a connection between the brain, to connect the brain to a computer and to transform the thought and the electrical activity into action. It was first studied in 1970s at the University of California. And we have many methodology to collect data from the brain, including functional images, near-infrared, SPECT, and EEG. We know that when you do a motor action, for example, moving the hand, and when you imagine the same movement, you have the same activities inside the brain in different areas. This is a study was done by a Japanese group in 2008, and what they did, they extracted the images from the occipital cortex. They presented images to the subject. Then after that, they extracted the same image using functional MRI, using complex paradigm. This is the video showing the presented image here, and this is the reconstructed image using functional MRI. If you concentrate, you can see it is almost close to the image that have been presented. EEG was started in 1924, and we know that we can transform EEG into SPECT. We can transform also EEG into sound. We know that the patient is seizing just by listening to the sound transformed from the EEG. In deep brain stimulation, we know that the deep nuclei can tell us a lot of things about the movement. The Toronto group now, they're studying to transform this activity and to apply it in brain-machine interface. This technology also used in neurofeedback to treat epilepsy, depression, and anxiety in addition to stress. Now moving to the EEG-based brain-machine interface, we can use non-invasive simple surface EEG, or we can use invasive EEG. The non-invasive EEG, we use the event-related potential, simply the sensory motor rhythm, or P300 waves. What is this P300 wave? It is event-related potential. Start with attention to the event after 30 milliseconds, and the other form of the wave is related to the cognition. It is respond very well to the oddball paradigm. When I do like this and this, I am provoking the P300 inside your brain now. You can train the subject to control his own brain activities and to take it, transform it to computer, digitalize it, and after that you can control other things like computer or robotic arm, as you can see here. And the other thing, you can also utilize it in games. Another thing in this one, also if you put this one, for example, on the head of your partner, you know that your partner is happy or not. The other thing, in invasive EEG, we can use surface, a cog, or grid, or subdural electrode, or we can use intracortical chip. Intracortical chip is a small chip, is only 4 millimeters. You can implant it. The best area to implant this one is the premotor area. You can study the brain activities, digitalize it, then after that send it to the computer and transform it into action. The best model for human is monkey, because you can train monkey so quickly. What you can do, you can give, in this study actually what they did, they give the monkey a handle, and the monkey will move it right and left, and they study the brain activities. So during the right movement, there is a special brain activity. They take it, then after that digitalize it and transform it into action. After that, they take this handle from the monkey continue to think the same. Movement to the right, move to the left. Then after that, they can transform it into action. This is the monkey which was published in Nature 2008. As you can see, this monkey cannot use hands. He's using only his thought, brain activities to control robotic arm and feed himself. Can we apply this human? Yes, a BrainGate team from UK, they implanted one subject. And what they did, they implanted a chip, they connected to a wire, and this plug was on the head, on the patient head for about 3 years. This patient started to communicate with others using computer, just using his thinking. He was trained to do certain things, and he can also check his email and do Google search. This is a video from the study from Nature, and you can see this is the same person who can control the prosthetic hand just by brain waves. The problem with robotic hand, it has only 4 dimensions, and the hand movement 27 dimensions. This is a picture from a science journal which showed a person who is dressing himself. You can see the complexity of the movement. The last slide. Can we help those group of patients? The answer is yes. Thank you.
Thank you. Comprehensive cover of that subject. Our next speaker.
So, assalamu alaikum. Thanks for inviting me, and appreciate my presence. I hope I'm not too boring. Especially speaking after Faisal, actually Faisal and Ibrahim al-Thabati and King Faisal Specialist. I think they're probably one of the most busy epilepsy surgery centers in the world. They do about anywhere between 150 to 200 cases a year for epilepsy surgery. Anyway, I'll try to start my talk here. We'd probably do 10 times less than you guys. Why is it not showing right? Anyway, it's all about teamwork. A lot of this information was prepared by Saad al-Rashidi, who's now in Halifax, and then the one who's taking over, accumulating the data is actually Abdul Majid al-Ahmari, who both are residents, and if not for them, I wouldn't have this talk today. Lahbib, who's going to speak after me, is the provider of most of our neuronavigation, and I would say that he's the secret of our success at the King Fahd Medical City. Shobit Sinha, Khurram Siddiqui, Fawzia Mukhaddam, Salah al-Mubarak are epileptologists that actually, without whom I couldn't have done any of this. Something wrong? It's okay. I'll start by our challenges. I mean, our epilepsy surgery program, our whole hospital is new, and our epilepsy surgery program started in 2008 with one epilepsy surgeon, that's me. Actually, I'm half epilepsy surgeon because I'm doing mainly pediatric neurosurgery and administration. There's 12 of us fighting for 3 operating rooms. And our institution we're required to do after epilepsy surgery. We're required to send patients to the ICU. So if there's no ICU bed, there's cancellations. And I was only given the introp MR suite to do these cases. So the advantages, one disadvantage is the slides. You can't really see much, but anyway, we have a dream team. A state-of-the-art 16-bed, currently we're using 8 beds, the epilepsy monitoring unit. State-of-the-art intra-op MR suite. State-of-the-art MEG, magnetoencephalography, that's my picture there, acting as a guinea pig. We do WADA, SPECT, and I'd call it futuristic neuronavigation, a neuronavigator who's going to speak after me, inshallah, Dr. Swalmi. Okay, so most of our cases in blue here are temporal lobe resections. I don't know. I don't know what's going on there. It's not my computer. It's your computer. Yes, it's done as Mac. Wow.
How about you present like this?
I can, but I'm not happy.
At least you can show your figures.
That's not right. Okay, so you're going to love my presentation, I think. So anyway, I'm just showing that most of our case, this is our first year. We doubled our caseload in the next year, but again, we're not really flying much over the past 3 years. That we're doing around 20-something cases a year. Our temporal lobectomy cases, we have a follow-up ranging up to 1.4 years. All of them get video electrocardiography, and video EEG and the EMU, and they all have pre-op MR. Functional MRI, WADA, and MEG are available in our institution, as we said, but MEG specifically, we started using it about a couple of 3-4 months ago, so we only done 2 patients for epilepsy. Most of the other patients were done for functional mapping. So our mean age is 24, 25 years, males more than females, right-sided more than left-sided, if we're talking about temporal lobectomy. Most of the cases had mesial temporal sclerosis, and the rest had several other pathologies like DNT, gangliomas. We had 5 patients that had no pathology, non-imaging and no pathology. For intra-op MR, so all of these patients were done in the intra-op imaging suite because of the luxury, or because I'm forced to actually do them there. And if you see that in 29 patients, in 10 patients, sorry, I had to go back and resect a little more of the hippocampus and or actually a little more of the amygdala that was not seen during surgery. I think that the caveat is the amygdala resection during epilepsy surgery. So that's our brain suite. And just to show you just a case here where this child has left temporal, mesotemporal, actually temporal lobe lesion. I usually map the patient like this. Where's the? I usually mark the skin like this, and I actually the family had shaved this patient, so I do it like that. But usually I don't shave. So that's my main cutting, is the incision, and these are dots that I leave there just in case I need to extend. The challenge with the MR head holder is this. It's like a cartridge. You're covered from 3 sides. You can only work from the exposed side. For epilepsy, it's not a big deal, and we just basically place the coil over the patient. You see, the coil is over the patient while doing the MRI, and we take it off, and we can operate. I'm a minimalist in terms of opening. This is a sort of a temporal lobe surgery that I'm doing here, where I put the invasive monitoring, a grid, a strip, sorry, and then I let the EEG, the epileptologist, actually map the patient. And even if I take out the amygdala hippocampus, if there is activity, then I'll resect the temporal lobe, or I do a disconnection. This is also another form of invasive monitoring. We're doing here, as you see, the depth electrodes, Spencer technique for bitemporal epilepsy case. This is putting grids, as you see, that the same grid. This is a patient that has a gliosis after a trauma and an intractable epilepsy. I put a depth electrode here. You see one depth electrode amygdala, one in the hippocampus. And then one was I put there in the insula, where there was some gliosis there, and then I put the grid. Afterwards, we realized that was the temporal, it was mainly a amygdala hippocampal discharge, and also another discharge in the parietal area behind the central sulcus. This is what we mapped, so that's what we did in the resection. Temporal disconnection is something that I'm pursuing now, and so far we've done 4 cases. Where I just mapped a small opening for the disconnection. I do a hippocampectomy, amygdala hippocampectomy, and then I disconnect. As you see here, this is a tractography MR. Intraoperatively, you can see that the temporal has been disconnected. Temporal pole is disconnected. Just as you see, this is one of my first cases, mapping the opening. As you see, it's a 2 centimeter, 2.5 centimeter opening here. I'm putting the strip and the depth electrode in the amygdala hippocampus. We're mapping, and then this is the epileptology team, and then we resect the patient, and we're finished. And that's the sort of, we're outlining the line. This is Dr. Swelmy's work, and he'll show you better pictures than mine. Our temporal lobectomy outcome is about 78% seizure freedom. With some had some improvement. 5 are still having, 50% are still having seizures. We're still following, and we'll see what happens. Extratemporal, we have had 7 patients so far. Half of them are seizure-free. And I say 7 because I just did one last week. So I'm not really going to comment on that patient. One patient with hypothalamic hamartoma, where we decided to disconnect the lesion. It was a large lesion, didn't want to get into the complications of which. That's just volume rendering of the lesion, pushing on the basilar artery and the optic nerve chiasm being pushed forwards. It's a prefixed lesion. And this is the approach where and she's seizure-free. After the surgery, she had a 3rd nerve palsy that improved after 6 months. So that's a picture of her after 1 year. Vagus nerve stimulation, again, the usual. We did 20 patients so far. Half of them had more than 50% seizure improvement. One of them is seizure-free for the past 3 years. One was seizure-free for about a year. But he was able to finish school, and he went back to work. After 1 year, started having some seizures. 5, and this is important, 5 of the patients reported mood improvement and and they felt their mood and their psyche had improved. And this is a study that we're doing with our neuropsychology department. MEG, again, we're using it for function and for EEG. That's Dr. Al-Mubarak, who just joined our department. So, and basically, it's for more functional than EEG monitoring. Complications, and that's, I think, this is an important slide. We had 4 patients that had complications out of 77 procedures. That's 0.5%. But even if we just look at resection patients, excluding the invasive monitoring and VNS and the rest, that would be 0.1% of the patients would have complications. And those included, one had homonymous hemianopia because I had to go a little posterior in the temporal lobe. One had a DVT, pulmonary embolism, and that was the first patient that I decided I want to do same-day surgery if you want. I want to send the patient home next day. And that patient developed a PE and DVT, so that was the lesson to anesthesia, not to trust me. But so far, I'm trying to send these patients to the floor directly. One patient had the 3rd nerve palsy. I just showed you that. Now, one of my temporal lobectomy patients committed suicide 4 months after, and we never knew why. He was okay before surgery and after surgery. They said they had some borderline personality, but again, that's something that one has to be careful with. In conclusion, epilepsy surgery is safe and effective. Technology is helpful. More studies are needed. We're currently looking into that. Keyhole surgery, as I showed, we do small targeted surgery using navigation. I think it has patients recover faster. Yet we need to look at that in a better scientific way. Our patients don't like to go home. They just don't want to go home. They culturally, they want to stay in the hospital until even taking out the stitches. Sometimes we just push them and they go. And I admire Dr. Bernstein's way of looking at it, and I'm trying. We'll see what's going to happen next. And most of our patients come from outside the city, so that's another issue. Intraop MR is helpful for epilepsy surgery, and I think Dr. Abdul Majid is going to present the literature review on that and our experience also tomorrow. So stay tuned for that. That's a picture of that's a picture of our NNI, the National Neurosciences Institute, where it's a 12-story building, 350 beds with 11 operating rooms, intraop MR, intraop CT, and a floor dedicated for research. That's going to be, inshallah, up within 3 to 4 years. The hole is already dug and they started building. Thank you very much, and I think I hope you enjoyed that talk of Lahbib more than you did for mine. I'm sure his talk is going to work better. Thank you.
Last speaker of this.
Good afternoon, ladies and gentlemen. My presentation today will be about intraoperative imaging, and the whole new dimension is bringing when it's coupled to the neuronavigation. Rapid progress in computer technology coupled with the advancement in neuroimaging has pushed forward the development of neuronavigation. Neuronavigation is basically this platform which is integrating all the data coming from neuroimaging to plan preoperatively and guide intraoperatively during the surgery. So neuronavigation is becoming this surgical reality tool which is used on a regular basis in neurosurgical centers. This classical workflow summarizes the platform on which neuronavigation is built, basically from the time of image acquisition until we start planning pre-surgically for that surgery. So we start by segmenting and outlining any relevant information for the surgery, and then we will use this information to guide during the surgery. To be of any usefulness, since we're working on different modalities in terms of imaging, we need to put all this imaging data in the same reference frame. We call it fusion. So the first step, you need to be sure that the fusion is done properly. Otherwise, any segmented information will not be correlated the perfect way with the other information. As you can see here, I'm fusing two types of anatomical information. We can use any type of functional information too. After doing that 3D reconstruction, we end up with some sort of 3D model which is representing and giving a global idea about the problem and giving us opportunity to plan how to address this problem. The thing is, with the technological advances, we're getting to that extent where we're getting color maps that are realistic in a way that they are showing almost the reconstruction like the real anatomy. Once we're done with the pre-surgical scanning and we start the surgery, the information available on the navigation platforms in the computers should be correlated with the real head of the patient. We need to put that information in line with the patient. Same thing, same techniques are used for craniotomies or for spine surgery. Basically, we need to choose points and correlate them, choose them on the computer and correlate them on the real anatomy of the patient. We can acquire a mesh of points that will be connected and correlated with a surface which is extracted in the computer, or we can do some sort of automatic registration since we have that intraoperative imaging available inside the operating room, so we can take advantage of such technology and no need to pinpoint no more and no need to have that hassle of doing that pre-surgical registration. The thing is, most of the time, when the navigation is using, I have a movie here because when we're using navigation using preoperative acquired images, when we're using on the navigation platform pre-acquired preoperative imaging scan, once we open the craniotomy and we start having CSF leak, we're facing that brain shift. It's a quite disorienting situation when you are using an imaging which is not correlated no more with the reality of the anatomy in the surgical field. So The intraoperative imaging is the solution because you can refresh your imaging data by taking a scan while the head of the patient is open. So you're taking rid of these problems, and you can carry on with the surgery. As you can see here, it's a panoramic view of the surgical MRI suite. And after taking that scan, you can carry on with the surgery. Another type of intraoperative imaging, volumetric intraoperative imaging, is for the spine. And as you can see, you have a reference on the imaging machine and the reference anchored on the spinous process of the patient. So you know exactly where the images are in space, where they are acquired by relation to the anatomy of the patient. And the correlation is done automatically. As soon as you push away the imaging machine, you can start your surgery. Here is almost the same flowchart. This is the reason why I presented the first one, where before we were using the whole surface of the hospital because imaging was coming from the radiology. Now we brought the system inside the operating room, and we are taking the imaging inside the operating room. So as soon as we're done with that intra-op acquisition, we can send it to the PACS system, send it to the navigation platforms. We can do any needed planning and then carry on with the surgery. The big advantage with that possibility of having access to the intra-op imaging is to do as much scan as needed, because you remove what you're removing, and then you take a scan, and then you assess the amount of removal. If it's needed, you can take another scan. So we're taking the scan while the patient is still on the operating table and the craniotomy is open. If there is any remnant, we literally can chase it as soon as it's safe for the patient. So the problem now is we get rid of that brain shift, and also no need to do the registration, which means we're minimizing the time of these things. Basically, now it's taking around 4 minutes and 10, 11 seconds to take a global scan. As you can see here, after that intraoperative scan, we can still go after the remnant, and we can track, like you see here, it's the ultrasonic dissector, and we are completing the surgery. Most of the time, to get to the ideal objective of the surgery, it's not taking that long. It's just taking a few minutes more, and you get out of the OR with what was planned in the pre-surgical plan. So after doing the surgery, you need to assess the amount of removal. You have many ways to do it. Like, it's just an example here where you can display the pre and the post images. You can put them side by side, and then you need to compare. But I find out that the best way to compare them is to put them in the same reference system. So you can have a sliding window, and you can assess the amount of the removal by going to any desired cut. And it's the best method because you can have some sort of background information that you can use and that can help you to assess the amount of the objective of the surgery. This way of doing things allows us to see few things. Like in this case, you can see before the pre-op scan and intra-op scan. And as you can see here, you have like I'm a Mac user. So basically, yes, here, what we can see is before, I'm sorry, but we have like, can you help me just go I want to go back one slide back. Yeah. More back. Okay, you can see that we have an expansion of tissue, which means the tumor at the beginning, we have assessed the volume. Once we start debulking that tumor and we relieve some pressure, we have a component of that tumor which are expanding, which means we have a heterogeneous type of tumor where the elasticity is not the same all over the tumors, which means you start with the first volume and at the end you ended like if the tumor is bigger than what you thought at the beginning, and it's because the elasticity issue. Also, what we did notice that at the beginning, prior to do any debulking and relieve cell pressure, we can see that it's difficult to assess the boundaries here. While after debulking a little bit, we can see the thalamus here, and we can easily delineate the boundaries of the thalamus. So, which means even if at the beginning we're not able to separate the tumor from any other structure, once you debulk a little bit, you can take a scan, and probably it will help you to differentiate between the tumor and the normal tissue. Here, because we're working in the same team, I'll be just quickly showing an example of Dr. Abdurrahman Sabbagh epilepsy case where we're using the navigation to tailor from the opening of the skin bone until we get to the objective of the surgery. As you can see here, it's a minimally invasive approach where we draw on the skin the sketch of the surgery, and after that we go to the burr hole, and as you can see on the skin, we're planning to do this sort of opening, which is minimally invasive approach. You can have an idea about the size of the surgery, and in any step of the surgery, we're tracking the dissector, and we know exactly where we are, even if we have that small opening. This is the big advantage of having navigation, because you have all the landmarks that you need to localize yourself. No need to expose more, because all the information is available and you can use it at any time needed. We can do also intraoperative recording, and as you can see here, we're accessing the amygdala and hippocampus, and we can precisely tailor the removal to do the surgery. Here is the disconnection, and the opening of the skull should be oval a little bit along the dissection line or a plane, so allowing you to do the dissection. And as you can see here, we're following all that surgical path just to see if we're going through that planned path. And as the same slide shown by Dr. Sabbagh, showing the disconnection thing. So basically what we're doing here as a conclusion, we can say that intraoperative imaging or coupled to navigation is helping preoperatively to plan for the surgery, intraoperatively to guide for the surgery, and while the patient is still on the table and the craniotomy open, we can assess the objective of the surgery. And we can do it safely for the patient. Thank you very much.
شكرا الحبيب. خليك الحبيب. We'll have now some chance to question. Any question regarding the neuronavigation from the audience, please? Okay, thank you, Dr. Habib.
Thank you.
Any question to Dr. Abdurrahman Sabbagh regarding epilepsy? Can we make the light on, please? Light on. Any question to our colleague, Dr. Faisal Utaibi, regarding rewiring of the brain? Any question to our colleague Mark Bernstein regarding awake craniotomy? Any question to our colleague Professor Erhard Lang, neurointensive care? Which one? Okay. You have a question? Okay. Any question to Professor Peter Andrews? oxygen tension monitoring. Okay, thank you. Now we'll have 15 minutes coffee break or 20 minutes.
Dr. Khalaf, I have a question, Dr. Lind.
Please?
No, for Dr. Lind, I have a question.
Okay, go ahead.
Dr. Lind, where is Dr. Lind? Dr. Lind.
Dr. Lang.
Dr. Lang? He left the hall? Yeah, he's there. Oh, thanks for coming, Dr. Lang. The question is that, here. You mentioned here there's inverse. You mentioned there's an inverse relationship between the ICP and the mean arterial pressure.
Yes.
So whenever, and you mentioned that the mean arterial pressure, the ICP follows the changes in the mean arterial pressure, right?
Yes, those are the two patterns that we observe.
So the ICP follows the mean arterial pressure.
Well, that is if autoregulation is lost.
Yeah, because if the ICP follows the mean arterial pressure,
then you have a pressure passive system where you have a perfect correlation between the two parameters.
Yeah, what I mean is that if you have the mean arterial pressure following the ICP, then this is autoregulation. But if the other
No, that's loss of autoregulation.
Yeah, if the other way around, there should be a third factor, which is the CSF as intermediate between the both of them. If the ICP follows the mean arterial pressure, the mean arterial pressure improves, and then the ICP drops.
Okay,
So
yes.
most likely there's a third factor, like the CSF flow, resorption.
It has nothing to do with CSF. It has to do with vasoconstriction and the reduction of the cerebral blood volume compartment.
So why?
It has nothing to do with CSF.
Yeah, this is in case the mean arterial pressure, the ICP follows the mean arterial pressure, not the other way around, no?
Now the concept is that if two parameters go in parallel, you have no autoregulation. Whereas if they go in another fashion, then you have intact autoregulation.
Yeah.
You have to revise your thinking in a way that if two things don't go the same way, it's bad, it's not good. So the good thing is if they don't correlate.
Yeah, but if they
That's counterintuitive.
If they happen simultaneously, but not if one of them follows the other one.
That's bad.
Yeah, if one of them follows the other one, like the ICP drops, the mean arterial pressure improves, it's different from when the mean arterial pressure drops, then the ICP goes up.
Correct.
So if the mean arterial pressure drops after the ICP, this is kind of autoregulation. The other way around, there's a third factor that plays in between them.
I didn't get the last section.
I can sit with you later on.
Okay,
Yes,
thank you.
yeah. Thank you, Professor Lang. Thank you very much.
So, error and patient safety for neurosurgeons. This is one of my hobbies, studying error. So, there are some patients we cannot help, but there are none we cannot harm. It's a medical and ethical reality, and even in this day and age, there are things like wrong-sided surgery, which we collected a bunch of cases on recently. There are two components of error. One is human factors, and one is system deficiencies. And this is an example of a system deficiency where this gentleman is laying his safety net as he goes. And of course, our job as surgeons or as airline pilots or whatever is to make sure the safety net is there before we start walking across the rope. So I'm very briefly going to talk about these things: definitions, incidents, literature, causes, prevention, some error research, and disclosure of error. So the definition of error is the failure of a planned action to be completed as intended, which is an error of execution, or the use of a wrong plan to achieve an aim, an error of planning. And it would have been considered wrong by reasonable peers. Patient safety is the minimizing of harm to patients arising from the treatments administered to them or freedom from harm from accidental injury. What's the incidence of error? It's estimated to be to cause about 100,000 deaths in the US per year, which would translate to about 10,000 in the Kingdom of Saudi Arabia. and these numbers are for now Saudi, about 200,000 extra hospital bed nights, about $900 million in extra costs. But the true incidence of error is poorly understood because most of the recording is retrospective, which is flawed. What about the literature on error? It's mostly retrospective chart reviews, very few prospective studies, and attention was initially raised by some high-profile cases, and I'm not sure if this made it to this part of the world, but this was the famous case in 1995 of the wrong-sided craniotomy at the Memorial Sloan Kettering Hospital in New York. And this made it to the public press. This was in the New York Times. So a lot of the initial error sort of advertising was through the public media. There have been a number of retrospective studies, as you know, and Canada joined in and did one of these. And if you just look at the bottom line, 7.9% of cases of 5,000 randomly accessed hospital admissions, 7.5% had an adverse event, and a third of those, 37%, were due to error. So the yellow column on the side is the percentage of complications which are due to error. What are the causes of error? So there's a British social scientist named Reason who's classified error, and I've condensed it further. Errors can be due to organizational factors, like the different staffing levels of nurses on the weekends. It can be task factors. So that's the clarity of a task. If a junior resident doesn't understand clearly what he or she is supposed to do on a certain procedure, that procedure is likely going to have some errors. And situational factors like equipment design. And the older neurosurgeons in the audience will remember when poor equipment was used. And here's an example. This was one of my teaching missions in Indonesia, and many of you in the room have never seen this. I've actually seen one in Toronto 20 years ago. This is an old craniotome with an electrical cord that you can't sterilize properly, and of course a bit that never gets sharpened. So these are errors waiting to happen. The other causes of error include individual factors like sleep deprivation. That will decrease as the work hour weeks decrease. Patient factors like comorbidities, and team factors like communication. And here's an example of my residents and fellows operating. One of them is asking the nurse something, and I'm sure you've all seen this regularly, that miscommunications happen in the operating room. You ask for an instrument, and 10 minutes later you say, give me the CUSA, please, the Cavitron, and they said, oh, we don't remember you asking for the Cavitron. So there are many delays and errors because of poor communication. How do we prevent error? We start by improving the measurement of errors. You can't fix something that you don't understand. You create a culture of safety, where it's safe to talk about errors, and you embrace a systems approach. You have to know what you're fixing. That's called root cause analysis. You have to understand that new ways may be just as flawed as the old ways. You need forcing and constraining functions, which I will define in a second. And you need to be able to challenge the authority gradient. A junior resident needs to feel comfortable challenging the staff if he or she thinks that the staff is about to make some kind of mistake or doesn't agree with the plan. And the airline industry has decreased its error rate by thousands of fold. It's done a good job. It's done a better job than we have in surgery. As for creating a culture of safety where it's safe for people to talk about error, a major obstacle to reporting errors and therefore learning to prevent them is the blame and shame culture, which is an immovable object, just like this elephant. And I'm sure that you people know what I'm talking about by the blame and shame culture, where it's difficult to openly discuss errors. Now, a forcing function is something that reduces the chance of error to zero. So you cannot put too much potassium chloride into an intravenous bag if the bags are already premixed at the factory. Similarly, you cannot operate on the wrong side of the head if you're using a surgical navigation system or an intraoperative MRI. Those are forcing functions. And this is the very original image guidance system, which was called the ISG wand, which was a Canadian invention in 1983. Constraining functions are things that reduce the risk, but not to zero. So a patient may not be admitted to the operating room in most hospitals until the site has been marked. That's a way of decreasing the chance of a wrong site error. Also, the use of consistent reminders and education is a constraining function. This is an example. Do you have this in your hospitals? So in our hospital, every 20 meters is the hand cleaner on the wall and this sign, stop, wash your hands. And you can't help but wash your hands 100 times a day because you walk by these things every 2 seconds. Similarly, we have these posters in all our clinics, all over the place. And then, of course, there's this system for disposing of sharps. It's almost impossible to do something bad with a sharp if you've got this thing, on every wall of the hospital. So these are systems that help decrease errors. And then, of course, ultimately, there's the surgical safety checklist. Is this used widely in Saudi? Has this been adopted? Good. So this will, again, reduce errors. So I want to tell you a little bit about some prospective error research that I've been doing. So it's a quantitative study of error in consecutive elective surgical cases in one neurosurgeon's practice. And people like Amro Al-Habib will remember recording the errors for me. If I left the operating room, they would tell me what errors happened in my absence. So it's all elective surgeries of myself since May of 2000. So I've been doing it for 12 years. Error was liberally defined as any act of omission or commission. Cases are entered prospectively by me at the end of every case into a database with type, severity, preventability, and impact. Here's an example from 2 weeks ago. I did this error with a fellow. We put on a Lexel frame for treatment of a brain metastasis in the Gamma knife, and my fellow and I forgot that this patient had a flap. So the pin goes right into the flap, and the flap is depressed. That's a bad error. This was a technical error. The preventability was high. The severity was major, but it had no impact. We got away with it. The patient had no consequence. So why would I do such a study? Because prospective determination of frequency of errors is required. We need to create a culture where it's safe to talk about error, and that will improve opportunities to learn about error and will improve morale and education among the team. So if I walk into the operating room and Amro Al-Habib tells me, Dr. B, we did this and this and this, and then we discuss it openly. It's an open discussion. And that's what we do now with the residents and the nurses and the fellows and the staff. We talk openly about error in my operating room. So as of last week, there were 2,004 elective cases. They're mostly cranial, because that's what I do, brain tumors. 86% had at least one error, and there were median of three errors per case. And if you just look quickly here in green, the clinical impact was transient, or it was permanent in 3%. 25% of the errors were considered major by me, and 80% were considered preventable by me, as I was the scorer. And again, the result, the types, most of them are either technical errors, contamination errors, equipment failures, or delays. So the final piece is disclosure of error. It's easier to disclose error in different cultures, and I'm not sure where you guys are. I gave this talk, and I did some work in Kuwait 2 months ago, and error was like a swear word. You couldn't talk about it openly. I'm not sure I think you're more advanced here in terms of discussing error. But what is the lowdown on disclosing error? What did I tell that patient that we put the pin into her flap and pushed her flap in? Well, in the old days, here was an old view of disclosure. The patient has no right to the full truth. He should only get so much truth as is good for him. And when the older people in the room, like me, were trained, this was probably the mentality. On the other hand, here's a better view from the old days. Never be afraid of confessing your mistakes. It is cowardly not to do so, and it may prevent others from falling into like error. That was Joseph Lister. Okay, honesty is the best policy. What's the second best policy? In other words, it takes some courage sometimes to be honest, but we have to do it because it's the right thing. The modern approach is that legal and bioethical thought support full disclosure to the patient of any error that any reasonable person would want to know about. How about peer disclosure? So we should disclose to the patient. How do we disclose to each other? Well, we have mortality and morbidity rounds. We have forums like this where I'm showing you one of my errors. And then we can show our errors to the world by publishing them. And here's an example of an error that I published 9 years ago, a surgical, where we almost did the wrong operation because the patient's the wrong x-rays came into the operating room with the patient. And I called it What's in a Surgical Planning Error, What's in a Name. And this was in Lancet in 2003. So I think we need to be prepared to talk openly at MM with the patient, with our residents, with our colleagues, in forums like this, and even in public forums like publications or in newspapers. Report our own errors, and it'll be a better world. Truth, like surgery, hurts, but it cures. And our father, Harvey Cushing, said surgical knowledge of value is built more on the mistakes than on the successes of past experience. And I'm sure many of the surgeons in this room will reflect and will realize that they've learned more from the mistakes they made than from the successes. So I would suggest that it's ethically acceptable for healthcare workers to make errors, because we're all going to do that, but it's unethical not to learn from the errors. It's our moral duty to study error. It's healthcare workers' moral duty to disclose errors. And it's patients' and society's moral responsibility to try to forgive. So if the more open we are, perhaps our patients, we will discover that our patients are more open about accepting error, because most patients understand that we are human beings, no more or less than human beings, and we can make errors. So when I became a resident or an intern back in the late 1970s in Toronto, one of the outgoing residents said to me, "Bernstein, there are 3 A's about being a good doctor." I don't know if you guys have heard this. It wouldn't apply because, of course, it wouldn't be A's in Arabic. Availability. That means be available for your patient. A is affability. Affability means niceness. And the third A is ability. So be available, be nice, and be good. So what are the 3 A's of a doctor who has erred? Acknowledge the error to yourself and to others. Apologize to the patient. And acquire knowledge so you don't make the same error again. Thank you.
Thank you, Prof. Bernstein. We'll keep the questions to the end of the session. Next, publication of yours, or possibly the publication of the neurosurgeon sitting next to you, maybe the most cited publication in Saudi Arabia and the literature in Saudi Arabia. So this is what Prof. Abdul Hakim Jamjoom is going to tell us now.
Thank you. This presentation is an attempt at reviewing the most cited Saudi neurosurgical publications in the literature. I think it's fair to say that modern neurosurgery has been at least 35 years old now in Saudi Arabia, from the mid-70s, from the King Faisal modern neurosurgery started. And over these years, many Saudi neurosurgeons have published articles. Now maybe it's time to reflect on these articles to assess using bibliometric methods. Bibliometry is basically evaluation of scientific publications quantitatively. It is basically looking at citation numbers for article. A citation number for an article is important because it does reflect its usage. It reflects its impact on the specialty. Maybe indirectly it reflects its academic strength. It's an important tool that's used for the calculation of the journal's impact factor and for the author's H and G indices, as well as it's a criteria for the ranking of universities. So in this study, we attempt to examine the contribution of Saudi neurosurgeons in the literature by reviewing the most cited publications. We identified and reviewed the 50 most cited Saudi neurosurgical articles in the literature. We used the data from Google Scholar in December 2011, and the search necessitated identifying neurosurgeons by name to look at their publications. We defined a Saudi neurosurgeon as any neurosurgeon who practices in Saudi Arabia, irrespective of nationality or duration of practice in Saudi Arabia. But the article they publish should have the title of a neurosurgical unit in Saudi Arabia amongst the affiliation of the authors in the article. For articles that are published in neurosurgical journals, we needed one neurosurgeon from Saudi Arabia to include it in the review. However, to eliminate gift authorships, when articles are published in a non-neurosurgical journal, we require to have 2 Saudi neurosurgeons to include it in the review. So this is the sort of information we collected for each of the articles. In fact, because of the duplication of numbers, we ended up looking at 52 articles, although the intention was 50. The citation range was, the maximum was 110, and the 52nd one was 21. So the mean is 35 citations. Pons and Lozano in 2010 in the Journal of Neurosurgery looked at the citation classics in neurosurgery. They identified a citation classic in neurosurgery that published in all journals as an article that had more than 400 citations, whereas a citation classic that is published in a neurosurgical journal is an article that had more than 287 citations. So hence you can see that our citation numbers of 110 to 21 this is the most cited is quite modest. So if you look at the mean citation rate of these 52 articles regarding to in correlation to the year, it's logical to find that the articles published earlier, they tend to have more citations. In fact, the median for the 52 articles was 1995. Hence, one should leave at least 10 or 15 years before searching for the article to find out how much it has been cited. There's no point of looking early because the number does take time. And this is the journals these 52 articles were published. This is the more common journals, and this is perhaps the less common journals. About a fifth were published in non-neurosurgical journals, and just under a quarter were published in journals with an impact factor of more than 3. Interestingly, the commonest journal was Surgical Neurology, which is the one that has changed to International Neurosurgery. Not surprisingly, articles published in journals with impact factor more than 3 had better citation rate than those with less than 3, but we did not find the difference between articles published in neurosurgical or non-neurosurgical journals. What was of interest is that none of the 52 articles were published in any of the Saudi journals. In fact, in another study, we reviewed the 50 most cited Saudi articles in the Saudi medical literature. And in fact, none of them was even neuroscience. I think this should be taken as an argument against establishing too many local journals. I think before we think of the Saudi Journal of Neurosurgery, we should support our Riyadh Neuroscience and the Pan-Arab Journal of Neurosurgery and make them as stronger journals before we add more to this. When we looked at the subspecialty of the 52 articles, we found that 35% of them were in tumor and skull base, and 21% were in pediatric neurosurgery, which is different from the literature, because in the literature, the best cited articles tend to be on traumatic brain injury and vascular. And I think that's perhaps a reflection of the nature of the workload of the contributors for the 52 articles. We now looked at the type of the research, and citation rate for that. Only 4% of the 52 articles were prospective, 62% case series, 31% case reports, no RCTs, no experimental work. Again, does reflect that there is definitely scope for a more of a quality kind of experimental research and prospective work. When we looked at the units that produce neurosurgical units in Saudi Arabia that published these articles, it was dominated, of course, by Riyadh, by two centers, and we compared the articles that published from Saudi Arabian center alone with those published included centers from elsewhere. And the observation is that we come back to this point that 3/4 of the articles, 52 articles, were from 2 neurosurgical centers. So hence, there's definitely scope for other centers to be involved. An article that published by Saudi neurosurgeons in collaboration with other international centers had higher mean citation numbers, 46 versus 33, which again means multi-center research and international collaboration should be encouraged. We finally looked at the contributors of the top 10 contributors of these 52 articles, and this is the list here, the number of articles they have amongst the 52, and the second line is the articles in which they're first authors and the total citation. I think the most important observation here is 5 out of the 10 in the top 10 list were non-Saudis, and 2 of them, in fact, Prof. Mifti and Prof. Fox, they are only here for a relatively short period of time. I'm not sure if it's 3 years or something like that. But definitely this means there is an argument to have the support of elite research minds here working in Saudi Arabia, irrespective of nationality. I think that definitely would be better than paying for people to have the names of Saudi Arabia on the articles, as this rather controversial letter that published in Science recently. So this study, there is some limitation. The information came from Google Scholar, which probably some people will doubt the accuracy for older publications, but I think it was definitely good enough for the purpose of the study for us. Alternative places to get information is Science Citation Index Expanded, and the other one, but of course you have to pay money to get the information for this. So in conclusion, I think when you talk in general about what determines an article to be top-cited, definitely the journal and the journal impact factor, the time of publication, the field of study, and the research type. For us here, we really need to work more on our research. We need to develop elite neurosurgical research minds. We have to promote the research culture amongst juniors by mentorship, by establishing designated academic neurosurgical units staffed by Saudi PhD holders, and maybe development of strong PhD programs linked to international universities. This is the list of the articles, 1, 2, and 3. Thank you.